A very good morning to all of you. So I'll be presenting my work on needle stick injuries. We don't have any conflict of interest or any financial disclosures to disclose. We as healthcare personnels, we are exposed to needle stick injuries, which we define as a percutaneous exposure where the skin is breached by a needle contaminated by blood. Hence, this needle stick injury poses a serious risk of transmission of blood-borne viruses like HIV, hepatitis B, and hepatitis C virus. As per the literature, needle stick injury poses a 0.3% risk of transmission of HIV, and mucous membrane exposure poses a risk of 0.09% for HIV transmission. So we aim this study to determine the incidence and identify the risk factors and outcomes for needle stick injury in a tertiary care hospital in North India. Just a demonstration of color-coded bins we use for hospital waste segregation and their disposal, and not to recap the needle in this way. Coming on to the methods. So this was a retrospective database review of all the needle prick injuries and the splash injuries recorded between 2015 December and 2023 May in the tertiary care eye hospital. It was according to the tenets of Helsinki Declaration, and written informed consent was taken. We first conducted a search of PubMed database using the keywords needle stick injuries and ophthalmology, which gave merely 4 articles. Data collection and documentation was done by analyzing the hospital's existing data records. Incomplete and vague reports were excluded from the study. As a protocol of institute, the splash injuries resulting in the exposure of mucosal or ocular surface to contaminated bodily fluids were also reported. As per the protocol, the needle stick injury is being reported in the hospital within 1 to 2 hours of occurrence to the HICC committee, and the proper analysis form was also being filled up. The CMO ensures the hospital has a written protocol and the followability of all the SOPs. Coming on to the results, 224 needle stick injuries were reported over a period of 7.5 years. The adjacent graph shows the year-wise number of needle stick injuries and the seroconversion. The seroconversion, we define it as the number of patients who turned out positive for any of the 3 viruses, that is HIV, hepatitis B, and hepatitis C. We can see the year 2017 and 2022, the number of needle stick injuries were on the higher side, and couple of seroconversion in 2019 and 2016-17, and 2022 we had 1 seroconversion. This is showing the distribution of needle stick injury among the healthcare personnel. The trainee doctors suffered the maximum needle stick injuries, contributing to around 47% of the cases, followed by the nursing staff. And the least needle stick injury was encountered by the housekeeping or the maintenance staff. This is showing the location-wise distribution of needle stick injuries, with maximum number being in the OT. It contributed to around 71% of the cases. Coming on to the discussion, 81,700 surgeries were performed during the study period. To the best of our knowledge, this is the first study with data records from such a long duration, and also including the observation from COVID-19 pandemic time. We observed highest incidence of needle stick injuries among the trainee doctors, which included both the ophthalmic fellows combined with the postgraduates, and it accounted for around 47% of the cases. This can be attributed to the fact that the hospital, being a tertiary center, provides training to the fellow doctors and the postgraduates. Their relative limited wet lab experience and different surgical learning curve could contribute to such a higher risk. We found a higher incidence of needle stick injury, around 2.74 per 1,000 surgeries, compared to Rishi et al., who documented a 0.07 needle stick injuries per 1,000 surgeries. We observed no seroconversion in all the 7.5 years. The CDC estimated a seroconversion rate for hepatitis B around 22 to 31%, for HCV around 0.5%, and HIV as 0.3% respectively. So do's and don'ts in case of needle stick injury at a glance. What we should not do, do not panic, do not put the pricked finger in the mouth, do not squeeze the wound or use bleach, chlorine, alcohol, betadine on the wound. What we must do is wash the exposed site thoroughly with the running water, or if soap solution available. What we recommend is to minimize the incidence of sharp injuries. We can follow hands-free passing, in which a neutral zone is being employed as an intermediary area. Despite the best efforts, some injuries are inevitable. My study had the limitation of being a retrospective, manually recorded database review. So initial part, some incomplete data was being left over. Concluding remarks will be there must be a proper training of the all hospital personnel for risk of NSI, protocol of reporting, and proper needle disposal mechanisms. These are my references. Thank you.
Thank you so much for touching on that very important topic. So I was just wondering, just a couple of questions to you. So we noticed that in 2022 there was a significantly high incidence. Any particular reason for that? Because as I see, over the years, it should actually, with improved protocols, it should be decreasing. But then in 2022, it was very high. So did you go into the depth of it and find out the reason?
So ma'am, post-pandemic, there was increased awareness among all the staff and population per se of reporting any sort of hospital adverse events. I think that must have contributed to a relatively more number of incidents being recorded on the database. That was, we thought, initially.
Okay, yeah, thank you. Another one, I was wondering, like, since the fellow trainees, as you said, had a high incidence of these injuries, so any steps you've taken?
So, ma'am, in the operation theater, we have another separate room for the block, for giving the perivalvular block itself. On the block room itself, the right and left eye patients are being there because the bulk of surgeries we are going through, there are a number of increased chances where we can miss the eye. So we have segregated the eye-wise the table for right. All the right eye patients are being laid on the right side of the room, on the left side, and proper disposal mechanism for every being arranged for every table. And we have increased number of staffs providing this syringes and blocks, and for the disposal, once it is almost 1/3 full, 1/3 to half fill, the staff is being replacing all the bins and the needle simultaneously.
Okay, yeah, thank you. But I was just wondering, you could, besides taking all these steps, you could also have a session, for
that
trainees,
is ongoing,
new trainees, so it's some kind of an induction, because like usually
all the staff
people focus on practices, techniques and all, but this is very important for safety of
at the time of joining, every staff and the doctors, they do go through the induction process. Yes, ma'am.
And you have a critical incident reporting system in place?
Not as per critical incident, we have all the needle stick injury reporting mechanism where it is being reported to the HICC and the CMO instantaneously within 1 to 2 hours of the incident.
So you should have a fixed protocol in place, which should also be informed to all the trainees and the staff. I think we can consider having an induction regarding that.
Yes,
thank you.